And thanks everyone for joining us. We're really excited about this conversation here, and we're hoping that it is an active conversation with everyone. Um, this one is a little bit different from the rest of the sessions that I've been listening to in here, and um, we're looking forward to getting into it. So, our session is Lessons from the Field, leveraging clinical research to fill gaps in mental health care for families. It's about clinical research, how clinical research can help address some of the biggest challenges we are facing in community mental health, things like limited access to care, financial barriers, and long wait lists to see physicians or clinicians. We'll share what we've learned from real world examples about how research partnerships can open doors to innovative treatments, provide structured support, and even ease financial strain for families. Most importantly, we'll highlight how families themselves can be powerful advocates in bridging these gaps. So, I'm Erica Moore. I'm the Director of Operations at the Starr Coalition, where Starr stands for Stakeholders in Treatment, Advocacy, Research, and Recovery. We are a nonprofit advocacy organization born out of conversations from clinical research leaders and advocates on that's mental health advocates and mental health clinical research leaders on how to find new and progressive ways to truly place the volunteer, the patient, or the individual living with the illness at the heart of the research process. Our work is around supporting successful clinical trials while ensuring that individuals participating in the trials receive the care and the services they desire, and ensuring that research is part of the continuum of options for everyone seeking help. I'm joined today by the STARS board chair, Carol Witham, who is the CEO of Pillar Clinical Research, and Andrea King, who is the clinical director at Inspiration Day Treatment Center. I'll let both of them introduce themselves before we dive in. So, Carol, if you want to, you're on mute. You're on mute.
See, that's the start of me displaying that I am not a professional presenter, but what I am is extremely passionate about this topic and individuals living with a serious mental health condition. So my name is Carol Witham. I'm the founder of the Starr Coalition many years ago and the CEO of Pillar Clinical Research. And am very honored to be a part of this conversation and really hope that it's a collaborative, lots of questions that are asked that we can help filter and discuss along the way. So pleasure to be here.
Andrea?
Hi, everyone. I'm Andrea King. I'm an LCSW, and I've been practicing now for almost 40 years, which seems kind of incredible to me. I've been at Inspiration Day Treatment for the past 13 years, and Inspiration Day Treatment has a wonderful background story. Carol Witham is also the CEO of Inspiration, and it was born out of research. The need was identified as a result of Carol's work with research, and she put together a treatment program that allows us to serve about 100 individuals with serious mental health issues who come into treatment from the community on a daily basis. And there's lots of challenges involved in this population, as I'm sure you all are aware, and we'll talk about those as they are related to financial issues, family issues, advocacy issues, and research. So happy to be here with you all today and look forward to some great dialogue.
All right, so before we jump in, just to let you know, please do feel free to post any questions you might have in the chat. And after we run through a few slides, it's just a few slides, then we're going to go into a Q&A and just a conversation. So you feel free to post your questions or just hold off until we get to the Q&A section. So to kick it off, let's go into the challenges. And Andrea, do you want to start us off with that?
Sure. Inspiration Day Treatment is a private treatment program. So we operate in a similar fashion to a community mental health center who might offer a day treatment program as part of their continuum. We are just doing that one thing. And I feel like we do that one thing very, very well. We've learned from a lot of trial and error. But we face a lot of the same challenges and are on provider organizations with our local community mental health centers, working to address particularly a lack of understanding and a lack of funding for the services that high need individuals require. And there just seems to be a lack, I'm sure you all face this in your practices, when it comes to working with payers, a lack of understanding of the unique needs and the significant amounts of support that clients with serious mental health issues need. And that extends not only to the individual impacted, but also to the family and certainly to the community as well. We want to be good community partners and include them. But there's a lot of stigma and there's a lot of lack of understanding that makes these treatment programs hard to find. And I think that's one of the frustrating issues for families is being able to understand how to access care, being able to understand exactly what their loved one is needing and ways in which research and treatment programs can partner together to help people get better. So a lot of that has to do with insurance, figuring out languaging for the insurance companies to make sure that those services are covered and that care stays intact. We've had a couple of clients just this month who've lost benefits. So going through the process with the state to understand what happened, what the change was, and try to get those benefits back so these individuals can remain in care. We also have, like a lot of the community mental health centers, workforce shortages. And again, that all kind of comes back to the financial piece and being able to pay our people well. We have a wonderful array of very dedicated staff who've been with Inspiration for a long time, and that makes a big difference in how care is delivered, right? We see that when a team is working together with a lot of harmony and know each other well, we can step in when things get tough and complete interventions in a way that helps get our individuals back on track. The CMHCs typically have pretty long waiting lists. That may be true in a lot of your communities. At Inspiration Day Treatment, we are typically able to get services delivered the next day following a call. And that has to do with the fact that we are small and we have a lot of autonomy, a lot of agency around how we take care of people. And so that's a little bit of a difference for us with the CMHCs, but they are under a lot of strain and stress too. And I'd be interested in hearing from those of you who work in CMHCs to see how you feel about how you all are able to navigate care for this particular population, the ones with very high needs who are complex medically, with their medication issues, and with their psychiatric presentation.
Before we leave you, Andrea, I know that with the changes of, when people lose their insurance or their insurance changes or their benefits change, and that's going to lead to them going off their meds or even changing their meds or something. In this population, it's particularly damaging, right? Are you seeing any of that happening?
Well,
and how might
that is obviously a concern, Erica, and we are addressing that every day from an administrative standpoint. We are working with state agencies, with government officials, to make sure that they understand what the needs of this population are and trying to get resources in place to support them. Certainly a day without medication in this sensitive population can make a world of difference. So we're going to continue to provide care for clients while we work on all of that background noise related to payment, but not all agencies are able to do that. And that's a reality of running a business. And I certainly understand that part of it. I've stayed with Inspiration for as long as I have because of the way we've been able to take care of clients sort of through some of those challenges. And that equals good care, even in the midst of a loss of payment or of someone who is needing extra support and care that may or may not get paid for. We're going to do that anyway to help keep them stable, to work to keep them out of the hospital. And Erica, I don't know if part of your question was related to whether or not we were seeing an increase in hospitalization. I would not say that we are, but I think just these are stressful times for people, and there's just an overall lack of wellness. And it's a little more challenging to get care delivered and to stay on top of some of the changes in presentation that our clients experience. And that's not atypical for them to do well for a while. And as you all well know, go through a period of time where their diagnosis is activated, they're having increased symptomatology, and they're at risk. So we've got to put hands around them to make sure that they are being well taken care of during those times.
That's awesome. Thanks. Carol, I know you're gonna before we go to your slide, I'm hoping that, and you are on mute again, just so you know. I'm hoping that you can give us, Andrea gave a little bit of an introduction on how Inspiration Day Treatment Center came to be. But I'm hoping that you can sort of expand on that, how that initially started, because that was all you. And
it's a lovely story.
It really is. It's a wonderful story.
So I promised I would stay on script because I, again, not a presenter, and I'm very passionate, and we'll be here for 3 hours. And I'm sure many of the individuals on this call really do not want to listen to all of that. And I'm happy to connect with anybody on this call after, because I know that we work a lot with different advocacy groups and individuals within those advocacy groups. We love to gain insight from different people's background and their thoughts and processes and ways that they can make the system better. But IDT was really created because I started research in a hospital setting, went private, and individuals were somewhat being coerced not to do studies, and then being challenged to not be able to have access to care after if they decided to do a research study. And I became very passionate about that because we would not have these discussions if it was oncology, cardiology, or any of those. And most of us would demand that we would know all of our care options for treatment. Right? We want to know every aspect, and there's so much bias within mental health that I said, well, I'm going to start a day treatment and let these guys have access to care. If you guys don't let them back in, they don't need to wait 90 days. So what was happening is the research center was actually taking care of people for years, and no means of financially making it sustainable, which I haven't figured out how to make day treatment sustainable at this point anyway, but it doesn't really matter. But that's how it was initiated, is because, because of the bias within research, individuals were not having the ability to make decisions regarding their own care. So that's how. There's a lovely story behind it, a very sweet story behind it, but I will spare the hours that it takes to talk about it. And the crying. I'm going to try not to cry on this call. We can kind of go into, if you'll go into my slide, I'm going to try to stay on script as much as possible, because I really want to have just organic conversations towards the end. I'd love to have time to do that.
Okay. Yep, we're on your slide.
Okay. So as far as talking about pillar clinical research, there's 4 sites across the U.S., all in the mid part of the country. And all of them have a very significant love for CNS. We do a lot of different kinds of studies, but CNS is really our passion. So all of them have inpatient settings and outpatient settings and do different studies. And just by the way, I can stop before I noticed on my screen that you can see a bed. I'm actually in Boston at a scientific meeting and happened to jump on this call. So just want to make you guys aware of that as well. So Pillar works specifically, there's a lot of investment made on boots on the ground. We call boots on the ground education on research. So every site has someone that goes out into the community and actually talks about what studies are going on, and communicating about that being a care option. However, many individuals either don't ever want to do a study or maybe don't fit criteria for study, but we feel like research is part of the healthcare ecosystem and we have a responsibility to ensure that we're taking care of people, whether they do a study or not. And so that's a little bit about how, what Pillar does. But we have found that in many circumstances, clinical research fills a lot of critical gaps within the system. One being, it provides families and individuals living with a mental health or mental illness innovative care, new medications, new technology for sorry. I lost this is a great group to get grace from, but medications and therapies that aren't available in most community settings. So for someone who's tried several options with limited success, that can be life-changing. We've seen that on numerous occasions where someone has taken an investigational product and has done very well, that they haven't done well with other antipsychotics or, an antidepressant or, and so there's also an element of financial relief. A lot of indigent patients or individuals who their insurance doesn't cover services. Research is at no cost. Can you guys hear? I'm having all kinds of things come up on my screen. Erica?
Nope, you're good.
Okay. So I'm on my daughter-in-law's computer here, and it keeps doing things that are odd. So when an individual or a family calls, none of the studies require payment or insurance information. So what's interesting with that is as individuals come in for a trial, a lot of times we identify things on their health care, in their health, based on labs, et cetera, that they wouldn't get in a primary care setting, that has saved their life. So not only is it potentially a benefit for individuals that maybe won't have access to care at all because they do not have insurance, it's also some individuals who could benefit by trying a different medication. But another thing is many individuals come in because they say, I have children, and I'm fearful that they may have the same illness, and I want to be a part of creating maybe a new pathway or a new option for my loved one. So many of the individuals go into studies that way as well. It also helps, there is no billing Medicaid or any private insurance. People can receive more comprehensive monitoring and support that way without worrying about denials or coverage gaps. So finally, some of the structure of research itself provides consistent, high-quality medical oversight. There's physicians at every research site that provide more intensive screening, health screening than you would receive in your normal PCP office or a psychiatrist. If you go into a clinic, or even if you went into IDT, what research does is provide more intense labs, EKGs, things like that. So it doesn't replace, research doesn't necessarily replace the standard of care, but it does enhance it. It gives families an extra layer of support and access, and just hope that there's a potential option out there. So when you step back and look at it all together, clinical research isn't just about testing new medications. It's about creating access to treatment and other ways to deliver high quality care. It eases some financial stress and gives families more control in a system that often feels almost impossible to navigate. And I think all of us probably on this call have experienced that, whether you're a family member, or individual, or even a colleague. So I think that's.
Yeah, you did bring
I
up
think
some, you brought up something about because as part of I'm hoping that most of the people on this call, I'm not sure, and I would love to get some input into this, how many people are actually familiar with research, whether that's, mental health research, pharmaceutical company mental health research, or yes, this is slide 3. It's just we're still on slide 3. um, but so I hope that people are still familiar with research, but and if not, we can quick talk about that. But just pop a oh good, Amy said she was in a diabetic study. So Carol, you had mentioned that other health issues may have come up when you're doing like, I guess, a screening for someone in a research study that that that
right.
can you talk a little bit about that?
Sure. So, when individuals come in for a clinical trial, and I'm going to give you a prime example because this just happened in the last 2 weeks, and I'll give you other examples post this. But we had a 14-year-old male come in with bipolar disorder. And he came in, his family brought him in for being involved in a clinical trial. Was, healthy, family said he was healthy. He looked healthy. And his labs looked great. But when we did his ECG, he had idiopathic hypertrophic cardiomyopathy. So it's like, it's the disorder basically where you see kids just drop, like they could be doing an athletic event or running or playing football and they just die. And this child had that condition and nobody knew about it. And nobody would have known about it probably until something would have happened. So the research site was able to get him the care that he needed to ensure that condition was taken care of and treated appropriately. So he would have never been able to participate in a trial because of his health condition at that point. However, it was a stepping stone for him to get the treatment that he needed to potentially save his life. We've had individuals that didn't know they had sickle cell initially. We had early onset of, some cancers that you would see certain labs that, our docs would be like, they don't look bad, but there's something not right. We want to do some further investigation of this. And so there have been numerous scenarios just on the medical component that has really saved people's lives that never even went into a trial they just were brave enough, and to me, they were a medical hero to even have the courage to learn about research and to participate in that process.
Yeah, it's amazingly, I forget how many, how important, you know, to one person, you change one person and it changes everything, you know. So,
Yeah.
all right, thanks, Carol. So this is our last slide, everyone. So
Erica,
Eric,
can I piggyback on something that Carol just said?
please do.
Okay. So when we think about research, we normally think about that happening someplace far away, like in an academic institution, in a big hospital. But research centers are available in our communities, and that's a big advantage to families who want to be involved and who want information, and can be educated through the process of joining with the research team and their loved one, to understand kind of how that process is unfolding. So it is accessible and important as a resource for us all to know about, so that we can help our clients navigate into whatever system they may need to further their care.
Yeah, I'm glad you added that, Andrea. I run into people all the time. I'll be on a plane and talk to somebody about what I do, and they will say, oh, we have a relative that's living with schizophrenia, and their medications aren't working for them. I want to, can we get them in a study? And I'll just say, go on clinicaltrials.gov and see if there's a study around for your family member. Yeah, I'm glad you brought that up, Andrew, because it is true. Um, there's research, there's research offices that are just private offices, just like a doctor's office everywhere. And yeah, if Carol, you want to?
Do you think that, one of the things that we talked about early on when we created the Starr Coalition, and the reason why it was created was just bias related to research. So you not only had that bias, but then you also had the bias within mental health. Like individuals couldn't make decisions, for themselves, or families shouldn't have choices. And that's what's so interesting about this. And I think as a clinician, we all have our own bias in regards to stuff. And I had been preaching bias through the Starr Coalition for a long time. And I was at an advocacy program, and they had it was a conference, and they were doing like laughing yoga. And I can remember I was with a client at the time, and I saw this, and I was like, this is the silliest thing I think I've ever heard. And the person next to me, she said, oh, you don't like that? And I said, no, that's the silliest thing I've ever seen. And immediately at that moment, I said, oh my gosh, here I am, I'm preaching to the community about allowing people to have options in their care. And if one thing works, whether it's nutrition or, laughing yoga, why would I be the person to limit someone from those options? And so I did a little test. I felt terrible about it. And so I went into the population at the day treatment, and there was probably 80 clients there. And I didn't say anything other than, hey guys, I saw this and I thought this was really interesting. And I wanted to get your feedback on what you think about it. And it was interesting because we played that laughing yoga clip to 80 of these clients. And, half of them, a couple of them left the room. It irritated them. Some of them were like, what is this, Miss Carol? Why are you showing us this? And the other half were laughing and thought it was the funniest thing and loved it and wanted to see if we could implement that within our own treatment program. So you can quickly identify that, even if it's one person out of that group that could benefit from something. And research is one of those, one blue-eye, one brown-eyed person. It's really hard to get into a study in the first place, not by my choice, but by some of the scientific reasons why there's limitations. But allowing individuals to learn about it, get educated about it, and then that's an option potentially. Why would you limit that? But we do that, I think, innately and unconsciously. And so it's discussions like this, and I think that's relevant to opening up the doors of conversations.
Yeah, that's I'm so glad you brought that up because stigma is a huge part of everything that we're talking about. Stigma against mental health illnesses, stigma against, people's own self-stigma. And then we have this whole layer of stigma against mental health research and research into, treatments for mental illnesses. And it's, I mean, for good reason, right? We were that's the how we came to have lobotomies and
Right.
um
Right.
you know what I mean? Like some terrible treatments happened through research, but now happily it is much safer. And I feel like, and I know I'm very biased in this because my family had a research site also, so I kind of grew up around this. But I feel like if going to get care at a research center, um, that you have a much safer kind of environment because there is so much oversight. There's so much oversight and so many people who are going to be monitoring that person. All different aspects of the person. It's kind of a holistic whole thing. So, I'm happy to say I feel like it's much safer than it
That's
would
one of
be.
the that's one of the things that we talk about when people present concerns about research is exactly that. How much oversight there is from nursing care to medical supervision. And we treat a very medication resistant population at Inspiration. A lot of them are on a regimen that is unusual because that's what works for them. And it's just through trial and error and having them be with us for such a long time that we're able to excuse me, parse out what works. We've got to have more resources. We need more medications, and the CNS studies, I think, have been historically, because of bias, kind of slow to burn. So to have those available, we need to educate our patients and their families about how that can be useful for them. I mean, just even in terms of respite for some of our families who are so fatigued and who really just want to quit and give up and let their family member go live on their own when they are going to receive a lot of consequences and difficulty by not being ready to do that. So research helps us bridge the gap for that.
Absolutely. And you think about how many medications. I've been doing this been in mental health 30, I don't know. Maybe I shouldn't say that. 30 plus years.
Carol, go ahead.
30 plus years. And there was a time that the only medications we had for psychosis, for instance, was Haldol. A lot of the typical antipsychotics. And so we have been a part of getting approved many of the atypical antipsychotics, the Seroquels, the Zyprexas, the Abilifys, the Aristadas, all the way to the new ones, the Caplytas, the Lamictals, the et cetera. And I look back and I'm like, it's because of the selfless acts of individuals that chose to participate in these studies. In my eyes, they've always been my hero because, I take medications sporadically. And when, I always think about every time I take something that someone selflessly did a trial in order for that drug to be approved so I could take it. And we experience that a lot with day treatment, in that many of those individuals can't ever do a trial or haven't ever been able to because of the criteria. However, they've benefited from those individuals that have done the studies to be able to take an array of different medications at different times that helps alleviate some of the symptoms. So just as an ad, this has nothing to do with our slides, actually, I don't think, but just wanted to add that for a little color.
All right, well, we'll hop back into the actual presentation here. Why this matters now. Obviously, we're coming up on some changes, right? We're coming up on some big changes in the US, and everything kind of leads to this, why this matters right now is with Medicaid changing, with the insurance restrictions, and with workforce shortages all happening at the same time, and all sort of feels like peaking kind of. Families are being forced to navigate a system that's stretched thinner than ever. And for many, that means fewer options and longer waits, and this is happening, and as this is happening, needs are growing more and more complex, and that's why we see clinical research as part of the solution. It's not something separate from care. It just provides access to another sort of avenue for high quality care and monitoring at no cost. And it gives families another path forward when traditional options just aren't enough. So maybe most importantly, families themselves are at the heart of this, and they're the strongest advocates for their loved ones. And when they're informed and supported, they can help to drive the change in their communities. So, I mean, that's what the Starr Coalition, we believe that the collaboration is the key. When researchers and clinicians and families, when they all work together, we can start to close those gaps and make sure that people are getting the care that they deserve. So this is why we're talking about this right now. I'd love to open it up and hear the audiences. If you guys have any questions or thoughts, whether you're a clinician or a policymaker or a family member, or someone living with a mental illness, your perspective matters to us. What you're seeing, what's working, what we can do together to make more, care more accessible for everyone. So feel free to unmute or drop a question. Yes, Amy, you wanted to, please?
I have a couple families that I'm working with that they're both families have a boy that they both had ADHD for sure diagnosis. The one had autism, but the families are looking at, for safety issues, removing the boys from their homes. And where in Montana, there is nothing as far as a live-in situation in this state. It's such a waiting list. But are some of the clinical trials like a live-in type situation? Because they're having problems regulating meds and just a lot of stuff that's a big obstacle.
That's a really great question. I think that, there's numerous trials out there, and I'm happy to connect with you after this meeting and help with identifying some potential resources around your area to help. A lot of studies that I'm involved with are for more acute. So individuals who, I'll give you a prime example, acute schizophrenia. So individuals that are symptomatic that you would put in the hospital potentially, or could benefit from hospitalization, could benefit from the trial. And there's a strict criteria for that. And we do those studies. There are a lot of kid studies for bipolar, schizophrenia, and autism. Some of them have an inpatient component that gives some respite care, even though it's not necessarily designed for that, but it does provide that. or some stability for a period of time, but it's not like a residential situation or something that somebody can come in for long periods of time. But sometimes it can get somebody off their feet, or family, just enough of a care, initiation of care to navigate the system. But there's lots of all ADHD studies, autism studies. Some are inpatient, some are outpatient studies.
Well, like the one kiddo, he's been sent a lot to the local psych ward and Shodair, but mom and dad both work. Their insurance has limitations. I don't believe they qualify for Medicaid. So yeah,
Mhm.
that's kind of the big dilemma.
Yeah, I mean, it's a potential, it's definitely a potential option that I can absolutely discuss with you his case or their case, and help with some resources for sure. We're seeing that across the country, kids, adults, where there's just not enough systems, or expedited systems, right, to take care of people. The waiting list is unbelievable. It's interesting. I have physicians that are friends, right, and I have a radiologist that's a friend of mine, and people will call and say, I need to get in for this mammogram, or can you look at this, my whatever. And, the care is very, very quick, and she can access and navigate very quickly. When she calls me about a mental health crisis, I feel as lost as can be. And I've been doing this and been in the system for over 30 years, where I'm like, okay, so they don't have insurance. There's nothing here. They don't qualify for this. I know everybody probably on this call can relate to what to what I'm saying, where I almost get embarrassed about how the something that's so important, the brain being the most important organ in our body, being treated as if it's not important, or it shouldn't be funded, or get over it kind of thought process. And I think obviously it's gotten better a little bit at times. I think we're better than, but the care is just not there. I mean, and the funds are not there for clinics to stay open. So navigating cases, Andrea and I talk about this all the time. I don't know how many, somebody that's even under insurance care and we can't get them a place to live. And so we're trying to house them in a hotel or house them in the research center that they're not in a study, but we're trying to just house people so they can stay stable enough to get to continue on their journey to recovery. So I can feel you. I can do what I can for sure.
Yeah, Amy, I grabbed your email address and I'll share that with Carol so that she can ping you, or I'll ping you guys, put you together after the thing. But yes, meds and treatments are not going to be perfect in 7 to 10 days, unfortunately, and uh, uh, they might not be perfect in 7 to 10 months. Um, then, yeah, I had a very close friend of mine whose son is bipolar for years, right? Um, and he was struggling, and she just, he was getting violent at the house, and she was saying, I'm just going to let him go, just let him go back to being homeless, because she was at her wit's end, and it just wasn't, you know, she was just at her wit's end. And I know parents, that happens to parents all the time, but yeah, so we did bring him to a research facility to maybe get involved in a clinical study. And I think I don't know, it was a bipolar study, and it was an inpatient study, and I think it was like 5 weeks or something, Carol. Um
Some of them are 5 to 6 weeks. Yeah. And
yeah. So, but anyway, does anyone
I'd
else?
be interested if there's questions regarding, because I've received questions along the way through the years where somebody's like, well, I don't really know about this. And how do we protect our patients? Does anybody have any questions related to that?
That is a good point. You mean, how do we?
So one of the things, I'm protective of all the patients that we serve, and their families. I will go to battle for them on a daily basis, and I know that most people that work um, in this indication typically are very protective. That's just our nature. We want to do what's right for them. It's can be a vulnerable population at times where someone's really symptomatic and maybe not able to make the decisions that they would make when they're stable. Sometimes people say, well, how do you know if someone knows what they're doing? Right. So in the research world, there's an institutional review board that oversees all of research for all studies. So it's kind of an independent review that oversees the sites in the U.S., academia, hospitals, clinics, et cetera. We have auditors that come out all the time just to evaluate the sites. But most importantly, there's when you're talking to your family members, or you're thinking about doing a study yourself, is understanding what the informed consent process is and making sure that any facility that you would go to explains that very thoroughly. They don't hand you a consent, they explain it to you and read it with you. And so that you understand all the potential risks, the potential benefits of the medication, all the procedures that will occur throughout the study, and being able to ask questions. So if you ever get to a point and you want to just pick up the phone and call a research center and just ask questions about if I referred a patient, what would you do? How would you do it, et cetera. Every clinical research site should be able to explain thoroughly and kindly about every process within the research journey, because it's a long journey to participate in a trial. But I'd be interested if anybody had questions regarding that.
We have one question. Allison asked if people are compensated when they participate in the trials.
So most studies do compensate individuals for their time and travel. So, it's different for every study of what that compensation looks like. I'm happy to say in CNS, that has changed over the years, where individuals are compensated pretty significantly for their time. But as I always talk to families and individuals that are going in, is we try to help navigate what those funds look like and where they go to. So individuals who are coming in, they're not just coming in to get a paycheck, that they understand what they're actually doing. But every study typically pays for compensation of their time.
And from the research that I've seen, mental health research studies pay significantly more than almost all other studies, because they are more involved and harder to screen patients into, and I think it's recognized that they're just more complex. The studies are more complex, the screenings are more complex. So,
and I think a lot of advocates have been involved in this process of improving the compensation for mental health. I think years ago it was probably paid less than other indications. So I think that that is definitely been driven by advocacy, which is great.
Yeah, it's fantastic. It's fantastic. So I'm just gonna, if anyone feel free to put a question in the chat. We only have a few more minutes left, so while I'm waiting for someone to put a question in chat, Andrea, you mentioned how families are sometimes in the situation where they are between what is covered by whether it's Medicaid or their insurance or whatever, and what's actually needed. Can you share an example of what that might look like in day-to-day practice?
Well, actually, I can. We are constantly really fighting for ensuring that our clients get the services that they need and that those services are paid so that we can pay our staff to be here to take care of our clients. And we're seeing just a real, like I mentioned earlier, lack of understanding of serious mental health needs and how complex those can be and how they can change over time. So we're getting denials currently in the area of the clients are stable, so they don't need these services because they're stable. And it's very akin to, you wouldn't take somebody off of a blood pressure medicine when they were stable on a blood pressure medicine. Why would you remove treatment from a mental health patient who's stable in a mental health program? And helping people to understand that. And again, that runs the gamut from families to legislators to government officials who are policymakers, and helping to present education that normalizes this experience so that we can anticipate that there are going to be periods of great stability and peacefulness in our clients' lives. That's what we're working toward. And then there are going to be times that are more challenging that we really have to push in and provide additional resources. Sometimes those are community resources. Sometimes those are other levels of care. They may have to go into an inpatient hospitalization, or they may need a research study to be able to look for time where they can be monitored and supported so that they're getting medication on a regular basis. Because what we know is that consistency works. We've got to have time for medication to work, for treatment to work, and for those types of supports to stay in place so that our clients can maintain some stability, and to not have those taken away just because a client seems stable in the moment.
I'm glad you brought up the community resources, Andrea. We had a question about communities in the chat, but also I wanted to say, I know the Starr Coalition works really hard to build community trust. And we will actually, with each of the research sites that we work with, we do a sort of a radius of 30 miles around that research site, and we will look at all of the different resources in the community, whether those are shelters or kitchens or clubhouses, what have you, or support groups, whatever. And then we will put a whole list of those resources together and then provide them to the research site so that they can share them with their clients. Because we know nobody in this ecosystem, nobody can do this themselves. There is no one-stop shop. We all have to work together to do this. I guess Carol, you had mentioned that you have a boots on the ground
Right.
people at each of your sites that are out in the communities, also working to build trust.
So I think with trust, trust comes down to doing what you say you're going to do, right, and treating people with kindness. I think my biggest compliment is when an individual comes into a trial and refers their family members or their individuals they go to treatment with, or tell their doctor about it or their therapist. Those are the that's the thing that drives most research sites, is that. But I think education is a big component to that. Is just what are the questions you should be asking? You should ask questions if you're referring. You should get educated about what should you expect. And they should be doing that. Many research sites, we tell people, hey, come to the site and visit. Just come. But we also treat individuals that never go into a trial. We do a lot of indigent care that we don't receive any funding for. But we understand when somebody makes a phone call to us, we've got to do something about it. We can't just ignore the fact that someone's in need or a family's in need. And so there's a lot of resources at the site that are utilized to navigate the system that's a giant. Sometimes very complicated and very discouraging. And so we have individuals out in every one of our sites. It's not a requirement per the FDA or IRB or anybody else. It's a requirement that we have within is boots on the ground, delivering, supporting, going to where the needs are, versus people coming to you. And I think that makes a difference because it's not all about a study. At the end of the day, there's plenty of individuals. We don't necessarily have a problem with recruitment because of that reputation. But it's more about who are the individuals that maybe could never do a trial but are going to benefit later on by that drug. So it's a long-term journey. It's not just a short-term get somebody in a study.
Yeah, when we work with new advocates, we always start off with, are you familiar with clinical research? If not, um, let me hook you up with a local site. And Tammy, you had asked, you know, how you would be concerned about telling a client to go visit a research. Well, you know what? Go to a research facility. If you don't know, and you want to know, and I recommend that you do, familiarize yourself with your options. If you're treating this population, and you're looking for other options, this is a pretty decent option. It's an avenue for you to take advantage of.
I would have to add to that. Would you have the same feeling if you had cancer and you've gone through chemo and you've gone through, your doctors, said, hey, evaluate your nutrition, you need to change this, and you're following that, and research is an option. Would you or your family be interested in doing that? Whether you would or wouldn't, would you educate the people that are depending on you to inform them of their options? Do you limit that? If that makes any sense. So I think sometimes there's that bias between mental health and other indications. I think I've mentioned that before. But I also think, you know what, they're just like, there's some great clinics and then there's some not so great clinics. So if I was referring in to a research center, I'd want to see where I was referring, just like I would when I refer to a psychiatrist. I want to know the psychiatrist we're referring to in a different city, or a therapist, as we're in. I think we're coming to the end.
Yeah,
But love to discuss that after this session.
Yes. So I have my email here on the screen. It's Erica at the Starr. I'm going to put it in the chat. So and I can connect anyone with the other speakers. Also, I put in clinicaltrials.gov is that's the sort of the go-to site. There's a notice up at the top of it says, since the government shut down, they're not keeping it, but you can still go there and see what trials are happening in your area. Just put in the criteria, whether it's the illness or whatever, and you can hopefully find something. Thank you guys so much. Appreciate your questions and participation, Carol and Andrea. Thank you.